Hey there, and welcome back to the deep dive.
Great to be here.
Today we are tackling a topic that might sound incredibly dense, maybe even a little intimidating. Musculoskeletal tumors.
Yeah, growths in bones and soft tissues.
Exactly. It's complex stuff, yes, but understanding even the fundamentals is powerful, especially if, you or someone you know ever needs to navigate this world.
It really is. It's a perfect example where a little bit of knowledge goes a long way in demystifying something that can feel, well, quite overwhelming.
Absolutely. And the source material for this deep dive is fantastic excerpts from a really foundational surgical textbook, Bailey and Love's Short Practice of Surgery.
A classic gives us a solid framework.
It really does. It lays out the core principles from identifying different types to understanding how they're investigated and managed.
Yeah, the fundamentals are all there.
Right. So our mission today is to dive into this text, pull out the most crucial nuggets of knowledge, and really make sense of the landscape, the different types, how they're found, the principles of dealing with them.
Focusing on what might surprise you or just be important to know.
Exactly. Okay, let's unpack this source material.
All right, and the sources waste no time getting straight to a key point. Musculoskeletal tumors involve both bone and soft tissue,
Right?
and they can be primary starting right there, or secondary, meaning they've spread from a cancer somewhere else.
And here's one of those really interesting insights, like right off the bat from the text.
Hmm,
When you look at the most common malignant tumors found in bone, they aren't actually primary bone tumors,
that's a huge point. They're secondaries. Metastatic carcinomas.
spread from other organs.
Exactly. That fact really shifts how you think about finding a malignant spot in a bone scan, doesn't it?
It does. The sources list the common culprits where these metastases usually come from.
Yeah, breast, prostate, lung, kidney, thyroid, and colon cancers are the big ones mentioned.
And the text notes, with people living longer with cancer diagnoses now, managing these bone mets is a growing issue.
A very significant part of cancer care, yeah.
The source material also touches on blood cell tumors that can show up in bone.
Right. Haematopoietic tumors. Specifically, it mentions multiple myeloma. That arises from plasma cells in the bone marrow.
Often causing multiple lesions, right?
Usually multiple, yeah. But if it's just a single spot, they call it a plasmacytoma.
Okay. So those are distinct from the primary malignant bone tumors, the sarcomas,
Correct. And the sarcomas are much rarer than metastases overall.
but really important, especially because they often affect younger people.
That's the key thing. Children and young adults. The text highlights the main ones: osteosarcoma, chondrosarcoma, and Ewing sarcoma.
We'll definitely dive into those. But quickly, what about soft tissue tumors?
Yes. The sources state these are incredibly common. Lumps and bumps people find.
Like under the skin or maybe deeper?
Exactly.
Yeah.
But here's the reassuring part. Only about 1 in 100 of these turns out to be malignant. A soft tissue sarcoma.
Okay, so malignancy is rare in soft tissue lumps.
Relatively rare, yes. But it still means you need criteria for figuring out which ones need a closer look.
Absolutely. Okay, let's really dive deeper now into the bone tumors. How does Bailey and Love classify them?
Well, typically based on appearance or morphology and what kind of tissue they seem to be producing.
So, like,
So you've got the metastatic and haematopoietic ones we mentioned, then osteogenic bone producing, like osteosarcoma,
all right.
chondrogenic cartilage producing, like chondrosarcoma, and then there are others, including Ewing's, which is sort of in its own category of small, round cell tumors.
And you mentioned age peaks for the primary sarcomas.
Yes, they often have characteristic age distributions. Osteosarcoma has a peak in adolescence, then another smaller one later in life.
And that later life peak is sometimes linked to other things.
Right. The text mentions links to pre-existing Paget disease of bone or even previous radiation therapy.
Interesting. What about the others?
Ewing sarcoma is typically seen in adolescence. Chondrosarcoma tends to occur later, usually from middle age onwards.
It's also fascinating how the sources point out specific named conditions that increase the risk of malignant bone or cartilage tumors.
Oh yes, like Maffucci syndrome, All-Ears disease, Paget's disease again. It highlights that predisposition can play a role.
It really shows the complexity behind why these develop.
Definitely.
Okay, let's circle back to metastatic bone disease because the sources give it quite a bit of attention. They usually spread via the blood, you said.
That's the main route. And while lungs and liver are top spots for Mets overall, the spine is number 3 for bone Mets.
The spine, okay.
And the text reveals this really fascinating anatomical detail about how they often get there. It involves something called Batson's venous plexus.
Batson's plexus.
Yeah, it's a network of veins around the spine and pelvis. And the crucial thing is, these veins don't have valves.
No valves, so
Yeah.
blood can flow backwards.
Exactly. Retrograde flow is possible.
Oh.
So if tumor cells get into this plexus, say from the pelvis or abdomen, they can travel to spine easily against the normal flow direction. It's like a highway for metastasis to the vertebrae.
Wow. That's genuinely incredible. A valveless highway.
It explains why the spine is such a common site. The sources also describe how these mets look on imaging.
Right, they can be different types.
Yes. Lytic, where they destroy bone, that's very common.
Oh.
Or sclerotic, where they actually cause new bone formation.
Like with prostate cancer mets.
Often, yes. Prostate cancer mets are classically sclerotic, or you can see a mix of dendritic and sclerotic changes.
And it mentions rare bone mets in kids, too.
Very rare. But things like neuroblastoma or radiotherapy can sometimes metastasize to bone in children.
Okay, this is great. Let's maybe walk through some of the specific primary bone tumor types the source highlights. What are the key features we should know?
Sure. Let's start with osteoid osteoma. Benign. Bone forming.
Okay, benign.
Usually small but causes quite severe pain. And the classic feature, according to Bailey and Love, is pain that's worse at night.
Night pain.
And this is key. It gets dramatically better with NSAIDs like ibuprofen or aspirin.
Ah, that NSAI relief is a big clue.
Huge clue. It's usually in children, adolescents. On X-ray, you see a dense reaction in the bone around a small central spot, the nidus.
Got it. And it has a bigger cousin.
Sort of. Osteoblastoma is mentioned as being larger, potentially more aggressive, often found in the spine rather than long bones.
Okay.
Next.
Osteosarcoma. This one's malignant. It makes bone tissue, or osteoid.
Malignant bone forming. Where does it usually show up?
Most common location, the text emphasizes, is around the knee. So the lower end of the femur or the upper part of the tibia.
The metaphysis region, near the growth plate.
Exactly. And it comes in various subtypes, including some less common ones that grow mainly on the surface of the bone, like peristeal osteosarcoma.
Okay. Switching gears to cartilage tumors.
Right. Osteochondroma. Very common and benign.
Benign cartilage cap.
Exactly. It's described as a bony projection sticking out from the bone surface, covered by a cap of cartilage. A key feature Bailey and Love points out is that it grows away from the nearest growth plate, or physis.
Away from the growth plate, that's specific. And its inner bony cavity is continuous with the main bone's marrow cavity. You can see that on imaging.
Can you have more than one?
Yes. They can be solitary, or you can have hereditary multiple exostoses where someone has many of them.
And is there a risk with these?
A small one. The sources note a small but definite risk of malignant transformation into a chondrosarcoma, especially if someone has the multiple form or if a solitary one starts growing or becomes painful in adulthood.
Okay. What about enchondroma?
Also benign, also cartilaginous, but this one grows inside the bone's marrow cavity.
Inside. Okay. Where are they common?
Very common in the small bones of the hands and feet, according to the text. Often found, incidentally, on an X-ray for something else.
So maybe no symptoms.
Often asymptomatic, yeah. Or they might present with pain or a fracture through the weakened bone. And like osteochondromas, they're linked to those syndromes, Allies and Maffucci, which carry a much higher risk of malignant change.
Got it. Another cartilage one.
Chondroblastoma, also benign cartilage. But this one has a very specific location, the epiphysis.
The very end of the bone, near the joint.
Exactly. Typically in adolescence, before the growth plates close, often causes quite severe pain, and the source mentions it can sometimes be surprisingly subtle on X-ray, so MRI is often more helpful.
Okay. And the malignant cartilage tumor?
That's chondrosarcoma. It has a really wide range of behavior, from very slow-growing, low-grade tumors to highly aggressive, high-grade ones.
Can it arise from those benign ones?
It can, yes. It can develop de novo on its own, or arise within a pre-existing osteochondroma or enchondroma. Diagnosing it accurately, especially distinguishing low-grade chondrosarcoma from benign lesions, requires careful correlation of the clinical picture, imaging, and pathology.
Sounds tricky.
It can be.
Okay, moving beyond bone and cartilage producers.
Huh?
What about cysts?
Right, the text covers simple bone cysts. These are benign, fluid-filled cavities, usually in the upper part of the humerus or femur in children.
And they cause problems how?
The cyst thins the bone's cortex, making it weak and prone to pathological fracture.
Ah, and if it fractures, there's that sign.
Yes. The fallen leaf sign. Bailey and Love mentions this. If a fragment of the fractured cortex breaks off and falls down into the fluid-filled cyst cavity, You can see it on the X-ray,
Oh, love that visual. Fallen leaf, so descriptive.
isn't it? Very memorable. Then there's the aneurysmal bone cyst, or ABC.
Also benign.
Also benign, but generally more aggressive and expansile than a simple cyst. These are filled with blood-filled spaces, not just clear fluid. Imaging, like MRI or CT, might show characteristic fluid levels within the cyst due to settling blood products.
Okay. What about giant cell tumor?
Giant cell tumor of bone, or GCT. This one's described as locally aggressive. It's not truly malignant in the sense of spreading distantly usually, but it can recur locally and be quite destructive.
Who gets it?
Typically young adults, aged 20 to 45, usually after the growth plates have closed.
And location.
Very characteristic location.
In the epiphysis, right up near the joint surface. Common sites are around the knee, distal femur proximal tibia, the upper end of the humerus, and the lower end of the radius in the wrist. Got it. Epiphyseal after growth plates close.
Exactly. Then there's eosinophilic granuloma. This is rarer.
Okay.
It's part of the spectrum of conditions called Langerhans cell histiocytosis. It often affects the skull or the shafts, diaphysis of long bones. The sources note it can sometimes look quite aggressive on imaging, maybe mimicking Ewing sarcoma, so biopsy is key.
I have fibrous dysplasia.
This is described as a benign developmental condition. It's not really a true tumor, more like a disturbance where normal bone is replaced by fibrous tissue and immature woven bone.
Can affect one bone or many?
Yes, monostotic, one bone, or polyostotic, multiple bones. Long bones, ribs, skull are common sites. It can cause pain, deformity, or fracture.
Any classic signs mentioned?
Yes. The text points out the shepherd's crook deformity, a bowing of the upper femur, and a ground glass appearance on X-ray.
Shepherd's crook, ground glass.
Yeah.
Okay. And finally, Ewing sarcoma.
Right. Malignant. It's a small, round, blue cell tumor, part of the Ewing sarcoma family of tumors.
Where does it typically occur?
Often in the diaphysis, the shaft, of long bones, but also common in flat bones like the pelvis or scapula.
And there's a genetic link.
Yes. It's strongly associated with a specific genetic change, a translocation between chromosomes 11 and 22.
How does it present? Pain, mass.
Usually pain in a palpable mass, yes. But Bailey and Love highlights that Ewing's can also cause systemic symptoms,
Like what?
like fever, weight loss, anemia, or a raised ESR. That's less common with other primary bone tumors and can sometimes make you think of infection initially.
That's a really important distinction. And imaging features.
The text mentions characteristic, though not unique, features like a permeative or moth-eaten pattern of bone destruction, and often a layered onion skin periosteel reaction as the tumor lifts the outer membrane of the bone.
Wow. Okay, that's a lot of specific tumor types. The range is huge.
It really is. And the sources summarize nicely that bone tumors often occur in quite characteristic locations and age groups.
And that point about epiphyseal tumors, ones at the ends of bones being more likely benign.
Yes, that's a useful rule of thumb, though not absolute. Things like GCT and chondroblastoma are epiphyseal.
So the sources really hammer home some key warning signs for bone tumors worth recapping.
Definitely. Non-mechanical bone pain,
Right.
pain that isn't just with activity, maybe wakes you up at night.
Right.
Pain specifically around the knee in a young adolescent is a big red flag that needs checking out.
Okay.
And of course, any suspicious findings on an X-ray, like bone destruction, a fuzzy margin, or that periosteel reaction.
Got it. Bailey and Love also briefly mentions the Ewing staging system.
Yes, it's a common surgical staging system.
Yeah.
For benign tumors, it classifies them based on whether they're latent, active, or aggressive.
And for malignant.
For malignant tumors, it combines the tumor grade, how aggressive the cells look, with its extent, whether it's confined within the bone, stage 1, broken out of the bone, stage 2, or has metastasized, stage 3. The sources note many primary sarcomas present as stage 2B high grade and extending outside the bone, but no distant mets yet found.
Okay, that gives a framework for thinking about severity. Let's quickly revisit soft tissue tumors before we move to evaluation.
Sure. Key takeaway again. Very common overall, but malignancy is rare, maybe 1 in 100.
And many have benign and malignant versions.
Exactly. Like a lipoma is a benign fatty tumor, a liposarcoma is the malignant counterpart, fibroma versus fibrosarcoma, and so on.
But there are definite warning signs for soft tissue masses that mean get this checked by a specialist.
Absolutely. The sources list these clearly, and they're crucial. If a soft tissue lump is larger than 5 centimeters, about the size of a golf ball.
Okay, size matters.
Yes.
Okay.
Also, if it's increasing in size, if it's painful, if it feels like it's deep under the main muscle fascia rather than just subcutaneous fat, or if it's a lump that's come back after being removed previously.
Any of those features should trigger a referral.
Yes, significantly raise suspicion for sarcoma and warrant specialist evaluation.
Okay, so suspicion is raised bone or soft tissue. How do doctors figure out what's going on? What's the process?
The sources really emphasize a structured approach. High index of suspicion, prompt investigation, and this is vital early referral to a specialist multidisciplinary team, or MDT.
MDT is key.
Absolutely. They frame the initial approach around a stop, think, investigate principle.
Hmm.
Don't rush into anything, especially not biopsy, without proper imaging first.
Stop, think, investigate. I like that. And the evaluation happens in phases.
Yes. Bailey and Love outlines 3 phases. Phase 1, ideally within 24 hours of presentation, is the basic workup.
Which includes
History focusing on that pain pattern, night pain, NSAID relief, physical exam, and crucially, a plain radiograph, X-ray of the entire affected bone or region.
whole bone, not just the spot.
Yes, to see the full extent and look for any other lesions, like skip lesions. The sources also make a specific point here. If it's back pain in someone with a known cancer history, or an older adult.
Think Mets or myeloma.
Exactly. You have to have a high suspicion. They even mention checking an ESR blood test, as a very high level, like over 100, could point towards myeloma. And always check for neurological signs suggesting spinal cord compression.
Okay, that's phase 1, phase 2.
Usually within the first week. This involves further staging investigations. Typically a chest X-ray, or more accurately, a CT scan of the chest to look for lung metastases.
Lungs are a common spread site for sarcomas.
Very common for both primary bone and soft tissue sarcomas. Also, usually a whole body isotope bone scan to check the rest of the skeleton, and maybe abdominal imaging like an ultrasound or CT, especially if a kidney cancer metastasis is suspected based on a lytic bone lesion.
And phase 3 is at the specialist center.
Correct. This is where the really detailed local staging happens. An MRI scan of the lesion is essential to see the precise extent within the bone and surrounding soft tissues.
MRI is key for local detail.
Very key. CT of the lesion can provide complementary information, especially about bone detail or calcification. And then, usually after all this imaging is done, the biopsy is planned.
Let's summarize the key investigations again. Plain X-rays.
Still often the most useful initial test for a bone lesion. Gives a lot of clues, but never enough on its own.
MRI.
Crucial for local staging, defining the tumor's extent, relationship to nerves, vessels, joints.
CT.
Good for bone detail, calcification, and essential for checking the lungs for mets.
Bone scan.
Good overview of the whole skeleton for suspected primary bone tumors or metastasis.
Abdominal imaging.
Important if you suspect a metastasis from somewhere like the kidney.
It really shows how the investigation strategy is tailored, doesn't it? Based on what you suspect and where that type of tumor tends to go.
Exactly. It's a logical workup, not just a shotgun approach. Each test answers specific questions needed for staging and planning.
Which brings us neatly to the biopsy, getting the tissue sample. The sources are really emphatic about the timing here.
Extremely emphatic. This is a core principle in musculoskeletal oncology, highlighted strongly in Bailey and Love. You only perform the biopsy after all the local staging imaging, the MRI and CT of the lesion is complete.
Why is that sequence so critical?
Because the path the biopsy needle takes, the biopsy track, is considered potentially contaminated with tumor cells. So that entire tract needs to be surgically removed along with the main tumor during the definitive operation to prevent tumor cells being left behind and causing a local recurrence.
So the biopsy has to be planned as part of the eventual surgery.
Precisely. The surgeon needs to know exactly where the biopsy was done so they can excise it. That's why ideally, the biopsy should be performed at, or at least in very close discussion with, the specialist surgical center that will be doing the main operation.
Makes perfect sense. It's not just grabbing a sample, it's the first strategic step.
Exactly right. And image-guided biopsies, using ultrasound or CT to guide the needle, are generally preferred.
Why?
Higher accuracy ensures you get diagnostic tissue from the right part of the tumor, avoiding purely dead areas, for instance.
And they mention specific needles.
Yeah, typically a Jamshidi needle for bone biopsies and a Truckett needle for soft tissue biopsies. They also briefly cover principles for open biopsy if a needle biopsy isn't feasible, or diagnostic stressing things like using a longitudinal incision placed carefully so the scar can be removed later.
Okay, so investigation and biopsy are carefully planned. Let's turn to treatment principles. How does the approach differ for benign versus malignant tumors?
It's completely tailored, as you'd expect. For many benign bone tumors, if they need treatment at all, it's often relatively straightforward.
Like what?
For latent or active Benign lesions, like maybe an enchondroma causing some symptoms. Simple curettage, basically scraping the tumor out of the bone cavity, might be enough. Sometimes bone graft or cement is used to fill the hole.
And those simple bone cysts?
The sources mention they might heal spontaneously after a fracture. If not, options include aspiration and injection of substances like steroid or bone marrow or curettage.
What about the osteoid osteoma with that classic night pain?
For that one, Bailey and Love points out that CT-guided radiofrequency ablation or thermocoagulation is now often preferred.
Heating it with a needle.
Exactly. Using heat guided by CT scan to destroy the painful central nidus. It avoids a bigger operation.
But more aggressive benign tumors need more, like giant cell tumors.
Yes, GCTs are locally aggressive, so they typically require more thorough treatment. Usually extensive curettage, often using a high-speed burr to clean the cavity walls, plus an adjuvant treatment applied locally like liquid nitrogen, phenol, or filling with bone cement, which heats up to kill any remaining cells. Sometimes medications like denosumab are used too. Or occasionally complete resection of the bone segment is needed.
Right. Now, for the primary malignant bone tumors, osteosarcoma, Ewing's.
That requires a full multidisciplinary team approach. Surgery is central, but chemotherapy and sometimes radiotherapy are critical components.
Chemo is really important for some of them.
Absolutely vital for osteosarcoma and Ewing sarcoma. It's usually given before surgery. That's called neoadjuvant chemotherapy. Two main reasons: to shrink the primary tumor, potentially making surgery easier or allowing for limb salvage, and crucially, to treat micrometastases, tiny deposits of cancer cells that might have already spread elsewhere, even if not visible on scans.
Okay, but not for chondrosarcoma.
Generally, no. Chondrosarcomas are typically resistant to both chemotherapy and radiotherapy. So for those, surgery is the main and often only curative treatment modality.
And the goal of surgery for these malignant bone tumors?
The goal is complete surgical removal of the tumor with a clear margin of healthy tissue all around it. And importantly, this must include excising the previous biopsy tract.
Right, getting rid of that potentially contaminated path. The sources define different surgical margins.
Yes, they describe intralesional, cutting through the tumor generally avoided; marginal, dissecting right on the tumor pseudocapsule; wide, removing the tumor with a cuff of normal tissue outside its reactive zone; and radical, removing the entire anatomical compartment containing the tumor.
And for sarcomas, you aim for?
Usually a wide margin is the goal to minimize the risk of local recurrence.
Does this often mean amputation?
Thankfully, not as often as it used to be. Bailey and Love states that limb salvage surgery is now possible in the vast majority of cases, maybe 85–90%.
How does that work?
The surgeon removes the segment of bone containing the tumor, achieving those wide margins, and then reconstructs the limb. This usually involves using a large metal implant, an endoprosthesis, to replace the removed bone and joint, or sometimes using bone grafts, either from the patient, autograft, or a donor, allograft.
But amputation is still needed sometimes.
Yes, if the tumor is very large, involves major nerves and blood vessels that can't be spared, if there's infection, or if a functional limb reconstruction isn't feasible.
And the source makes a really important point about survival outcomes comparing limb salvage and amputation.
A very crucial point. While limb salvage might carry a slightly higher risk of the tumor coming back locally in the limb itself, studies have shown there is no significant difference in overall survival rates compared to amputation, provided the tumor is removed completely with adequate margins in both scenarios.
That's huge for patients making decisions.
Absolutely. The focus is on achieving cancer control while preserving as much function and quality of life as possible. Of course, these big reconstructions aren't without potential problems. The text mentions risks like infection, implant loosening, or breakage over time.
Okay, now shifting, completely treating metastatic bone disease. The goals are different, right?
Totally different mindset. Surgery for bone metastases is almost always palliative, not curative.
Meaning
the aim is to relieve symptoms, primarily pain, and to restore or maintain function by preventing or fixing fractures. It's about improving the patient's quality of life during the time they have. It might involve stabilizing the spine if the spinal cord is threatened, or fixing a long bone that is broken through a metastasis or looks like it's about to break.
So deciding whether to operate involves weighing things up.
Definitely. The sources list key factors: the patient's overall prognosis and expected survival from their primary cancer, their general fitness for surgery, their quality of life goals, the actual risk of fracture, how many other bone lesions they have, and whether the lesion might respond well to non-surgical treatments like radiotherapy.
They mention a specific score for fracture risk, the Mural score.
Yes, the Mural score is a system that tries to quantify the risk of fracture in a long bone metastasis based on factors like the site, size, type, lytic sclerotic, and pain level. It helps guide the decision on prophylactic fixation, fixing the bone before it breaks. But the text also cautions that its predictive value can be variable.
And the way you fix a metastatic fracture is different from a normal fracture.
Often, yes. Because you can't rely on the bone healing through the tumor, the surgical construct needs to provide immediate, durable stability, allowing the patient to bear weight quickly. So, for lesions near joints, prosthetic replacement, like a hip or shoulder replacement, is often preferred over trying to fix the fragments. For shaft lesions, strong intramedullary nails that span the whole bone are common.
But there was an exception mentioned where you might actually excise a metastasis.
Yes, a specific situation. For a solitary bone metastasis, particularly from certain cancers like breast or kidney, if the patient otherwise has their systemic disease under control and potentially a longer expected survival, the source suggests that complete excision of the metastasis and reconstruction, similar to a primary tumor, might be considered. This could offer a more durable local solution than just fixation.
That's interesting. And radiotherapy's role?
Very important for pain relief from bone mets, often used either instead of or in addition to surgery.
And that specific warning about kidney cancer mets.
Yes, renal cell carcinoma metastases. The text highlights they are often extremely vascular. They bleed a lot.
So, surgery can be difficult.
Very bloody. They mention that preoperative embolization is often recommended,
What's that?
using interventional radiology techniques to block the main blood vessels feeding the metastasis just before the surgery, to significantly reduce intraoperative bleeding.
Okay, practical point. Finally, wrapping up treatment, soft tissue sarcomas.
Primary treatment is wide surgical excision, again aiming for clear margins all around, and including the biopsy tract. Radiotherapy is often used as well.
Before or after surgery.
Can be either. Adjuvant radiotherapy after surgery is common. Preoperative neoadjuvant radiotherapy can sometimes help shrink tumors, but, as the text notes, might increase the risk of wound healing problems after surgery.
And chemo?
Chemotherapy generally plays a more limited role in most types of adult soft tissue sarcoma compared to its importance in osteosarcoma and Ewing's, though it's used in specific situations or subtypes.
Wow, okay. That was a really comprehensive dive into musculoskeletal tumors, all drawn from Bailey and Love. We've gone from common benign things to rare cancers.
Yeah, huge spectrum. And there's one thread running through all of it in the source material. It's that message about vigilance, proper investigation, and getting patients to a specialist MDT early.
Absolutely. Recognizing warning signs, investigating logically, planning biopsies carefully, tailoring treatment. It's all crucial.
It really underscores the need for that coordinated expert approach.
Exactly. And understanding these details, even at this level, isn't just for doctors, is it? It's about being informed, being empowered if you or someone close ever faces something like this. Knowledge helps navigate those complex medical paths.
Couldn't agree more. It demystifies the process.
So what's the big picture takeaway? This deep dive really highlights just how incredibly personalized the approach has to be for every single tumor. It's definitely not one size fits all.
Not at all. The specific type, the grade, the stage, the location, the patient's age and health.
Yeah.
It all feeds into the decision-making.
It's amazing. What detail from our discussion today surprised you the most, thinking back? Maybe that Batson's plexus route for spinal mets, or the fallen leaf sign, or perhaps just the sheer number of different benign entities.
I think for me, it's often the nuances like the critical importance of biopsy tract excision or the different roles of chemo for different sarcoma types. It shows the level of specialized knowledge required.
Yeah. It makes you really consider the depth of expertise involved in putting together the best plan for each individual patient.
It certainly does. A profound appreciation for the whole process.
Absolutely. Well, that wraps up this deep dive. Thank you so much for joining us as we unpack this really important, complex topic using the source material.
My pleasure. Always fascinating to explore these texts.
Until next time.